Hi guys, welcome back for another video. Today we're talking about hypertension disease in pregnancy. Make sure you're able to differentiate between chronic hypertension and gestational hypertension. Now in chronic hypertension, it can present before conception or at less than 20 weeks of gestation. Alright? And it can be diagnosed postpartum if the blood pressure is increased for greater than 12 weeks postpartum. Okay. Now, 1/3 of patients who do have chronic hypertension then get pregnant, they develop superimposed preeclampsia. All right. So you have to be able to just know if the patient has hypertension in pregnancy, is that if that's chronic or if it's just truly gestational. And this is one of the, basically it's the defining fact. These are the defining factors. Okay. Now in gestational hypertension, it develops at greater than or equal to 20 weeks, and systolic and diastolic is here 140/90, and it's measured twice, 4 hours apart, without significant proteinuria, meaning the proteinuria should be less than 300. Okay, 25% of patients who develop gestational hypertension will eventually develop preeclampsia, so you need to monitor the patient always. And always try to normalize the hypertension within 12 weeks after pregnancy. Now, if we move on, the treatment is very simple. You always have to do close monitoring of the blood pressure, but the best initial treatment is hypertensive medication. Now, the hypertensive medication are short-acting. I'm not sure about alpha-methyl-dopa, if that is short-acting, but I do know that hydralazine, labetalol, and nifedipine is short-acting. Hydralazine and labetalol, you're going to be giving the patient IV, and then these would be oral. Okay. Remember that labetalol can cause bradycardia. Okay. And then also that in hydralazine, you should have to watch out. You're gonna have to watch out for hypotension. Okay. Now, if your patient is vomiting a lot, and so if the patient's vomiting a lot, give the patient IV hydralazine or labetalol. Okay. Super important right there. And remember, hypertensive disease or hypertensive crisis is greater than 160 systolic or a diastolic greater than 110 with end organ damage. Okay. Also remember, don't take any ACEs or diuretics. Eventually it leads to uterine ischemia, and if you take an ACE, especially in those first 2 to 8 weeks, it's very teratogenic, so it can cause renal defects. Okay. Complications for gestational hypertension or chronic hypertension are listed right over here. You guys can see that. Okay. But that's pretty much it. So just make sure that if they ask it, just make sure you can be able to differentiate between chronic versus gestational. The weeks are very important here. So chronic is less than 20 weeks, and then gestational is greater than 20 weeks. Okay, not too much protein, but there is protein in gestational hypertension. And then treatment is one of these, any of these four. And then watch out if, for these causes, hypotension with hydralazine, labetalol, bradycardia. If the patient is vomiting, then you give IV obviously. But these are given orally. IV, and then these are given orally. Thank you very much. I hope that helps.